we're here for the exploring a new resource with Ohio. This is actually really exciting. This has been a session that it's close to my heart, and I think a lot of people's here. So I guess before I'm going to introduce Jen, I just want to give a little background. There are some amazing counties in Ohio, and I'm not trying to throw anybody under the bus, but Lucas, Franklin, this is actually not being thrown under the bus. This is like, these are the people that just come to mind. Butler has been really active. Hamilton County has been really active in saying we need more Summit's another really great one, who are saying we need to do more things for people with IDD who are aging and or their caregivers who are aging, right? This is kind of where it all came about. I think we had a session here a couple years ago, The Future Is Now, that Hamilton County gave, and that was more about the caregivers and helping plan for the future. And out of that, we've created a somewhat small little task force of people who want to figure out what are our lacking services, where's the gaps, what are we doing well at, and what can we do better? And out of that, those meetings over the last couple of years, we've actually joined with an already established group called CARRY, which is the Collaborative for Adult Resources, that kind of started out of the Hamilton County Southwest area, who were already looking at similar issues of gaps in services for caregivers of aging people, aging people, whatever, everything. So last spring, there was an NTG training, which is, I'm not going to say the right thing, Jen. Tell me what NTG stands for.
Group on Dementia and Intellectual and Developmental Disabilities.
There you go. You know some of this, don't you? You're nodding. Do you want to talk? Anyways, we got connected with NTG. And they kind of started joining our group, and they loved Ohio. Hamilton County hosted a great training down there, and people came, providers came, and NTG, we have official trainers now. And that then somehow turned into this amazing call that somebody from the Ohio Council for Cognitive Health, Bonnie Berman, who Monica, she stepped out. Monica introduced me to her. They called and they said, hey, we think there is a great opportunity with the Gerontological Society of America. And I was like, oh, I think this is big. So rest assured, this is where we got very quickly because of this amazing woman. So if I was doing the Lisa introduction, I would say no more words are needed. She's from the Gerontological Society of America, and she has been a go-getter in helping get this going for the entire United States, but really, really appreciating and utilizing the expertise in Ohio to make that happen and collaborating with us. So Jen Pettis, she's the Director of Strategic Alliances at the Gerontological Society of America. At GSA, Ms. Pettis directs the development and production of strategic alliances programs to further the Society's mission and strategic goals. Her responsibilities include providing thoughtful, leadership to drive growth and new opportunities involving existing or potential new partners for the Strategic Alliances Division of the Society, developing and managing key relationships and alliances, and representing the Society at strategic partner meetings, professional conferences, and meetings with communities of interest. Ms. Pettis also provides subject matter expertise to the Centers for Medicare and Medicaid Services regarding the minimum data set resident assessment instrument. Oh, I don't even know what that is. She's a member of the Alzheimer's Association of Northeastern New York Board of Directors and an active community educator for the Alzheimer's Association, as well as a volunteer lead trainer for AARP's Disrupt Aging Classroom Program. In 2020, Ms. Pettis was recognized by the National Hartford Center of Gerontological Nursing Excellence as a distinguished educator in gerontological nursing. And in 2021, she received Sigma's Amy J. Berman Geriatric Nursing Leadership Award, an international award bestowed upon an individual who has demonstrated contributions to collaborative practice through involvement in interprofessional teams and defined commitment to gerontological nursing. So needless to say, she's pretty cool. And more importantly, she identified Ohio as being a leader and and equally important that I was. And I got to go to the Gerontological Society conference and represent kind of the IDD community at large for the United States. And of course, I dropped Ohio a lot of times and told them how great we are. So really thankful for Jen. She's going to tell us about what we're doing. I'll jump in some, but really think about what this is pretty new. And we need buy-in from some counties to help us follow this along and make sure that we really launch this well. So.
All right. Thank you so much. And one thing you didn't hear Lisa introduce me as is an expert in IDDD. You guys are the experts. I'm not at all here to share my insights into your specialty, but I'm here to share with you a new resource that we want you to take and run with and get folks who are much less expert than you in IDD up to speed on how they can better serve the constituents that you serve. And so that's what this really is about. And we have about 53 minutes. It's like I have a buck worth of content in a 50-cent slot, basically. We have a lot to cover here. I do want to mention that our toolkit, our companion to this toolkit, so I've been out with this toolkit on my counter table, and I want to acknowledge that I want to hear from you guys today about how you can envision using not only this toolkit, but the new companion to this toolkit that is currently in design. But what I've made available to you while it's in design is an extra handout of a summary. It's all the tables that are included in that resource. So you guys can access these now online in your portal for handouts and things.
Yeah, it's in the OACB Member Connect with this. And if it's not yet, it will be. So it'll be important to look that up.
Okay. And then in this presentation, I'll share with you what's in this main toolkit and then share with you what's coming out in the companion. So the idea is that primary care uses this toolkit as an opportunity to pick and choose resources and pick and choose things that they want to do in their practice, all about driving earlier detection of dementia. We know that dementia is recognized too late. How many of you have ever gone to your doctor and they've done anything to check your brain except ask you the PHQ 2 to 9 about depression, right? And we would never accept that we leave our doctor's office without them listening to our heart, but they never check our brain. And so our issue is to really get folks earlier conversations and normalize conversations around brain health. And I think particularly in the population, in certain populations that you all serve, there's that idea that, oh, they're going to get Alzheimer's anyway. What's the point of even having conversations? And the message that a couple of really key messages in the new companion are all about elevating the idea of early intervention around brain health. Basically, it's good for your heart, it's good for your head. So we want folks to be engaging in conversations across the lifespan with people about what they can do for healthier brains. And even someone who is 90% likely to become affected with Alzheimer's, they still can do head healthy, brain healthy things that can help their cognition stay better longer. Simple things like, if you need hearing aids, wear hearing aids. That's come to be known as a huge risk factor for dementia. If you think about it, if you can't hear, your brain's going, wait, what did they say? What do I hear? I need to process that first and then process what I'm supposed to do with what I just figured out they said. So it makes perfect sense, but there's really strong research around these kinds of risk factors. And so those are the conversations we want to drive. So anyway, let's get into the PowerPoint. Do I have a clicker?
I got one. I just did it for you. If you want
a clicker. Yep.
I'm
kind of a control freak.
That's all right.
And I want to acknowledge that one of the things I want to leave here with is I want some great quotes. We're going to have some time that we're going to put in our design quotes. So Sally, my buddy here, is going to be taking some notes of things that you guys share with us. Our online audience, I don't think they can see us, right? They just see the PowerPoint.
They can see you right
there.
Hi,
I didn't know that. But we want to hear from you guys, so you can chat in as well. And we'll have your name. If you want to be quoted, say something brilliant, and we will probably quote you in the toolkit, even if it just kind of sounds catchy, even if it's not brilliant. You might end up in the new companion with your name if you'll give us a permission to do that. Otherwise, we'll say secret person from Ohio.
Anonymous Ohio.
So let's get into it. Here's what we're going to do today. It really is looking at opportunities to improve brain health. And I have my notes. I'm just going to look at it so I'm not looking back behind me. I'm going to tell you about this GSA care framework, where it came from, how it benefits individuals, ultimately the person with dementia or potentially their care partners. And then we'll look at the tools and resources in the current kit, and I'll give you a snapshot of what's to come within a couple of weeks. And I'm sure Lisa's going to blast out the new companion when it comes, right?
Yeah, we will definitely be blasting it out. And hopefully we have a few counties identified that we'll be meeting together with to talk about how we're going to do it.
I want to draw your attention to the QR code. Lisa said that I'm cool in the beginning. My nephew, when he was about 3, was like, Aunt Jen, you're really not that cool. So he's about 25 now. That's kind of scarred me for life. But I am cool enough to make my own QR code. So if
she does podcasts too. She's like a podcast queen. Yeah.
But if you want to be cool too, you can scan this and you can follow along on an interactive guide. The posters that you have give a nice snapshot. They include another QR code. Also takes you to all of our brain health work. Everything that we do in my division is completely free. We just want people to use it. That's our goal, is to get it out there and get it in the public. So please take a poster, take a few if you've got colleagues that might be interested. Otherwise, I'm going to have like an overweight bag going back to New York tomorrow, and I don't want to do that because then I have to like drag out all my clothes and it gets embarrassing. So take some home. I do have about 15 or 20, probably 15 toolkits left too. If you're dying for a toolkit, I'm happy to give you one of those too.
Yeah, and we'll talk about that. If they don't take them, I have people that okay. Ohio Health wants more.
People. She has people. People. All right. So who is GSA? I'll give you all my my dirty, dark secret. I can't believe it's taken this long for me to tell you. I am a nurse. Spent my whole life in long-term care and working with older adults. It's what I care about. It's what I'm passionate about. I work a lot in the dementia space. I'm nowhere near the expert that Sally is in dementia, but I really have a lot of passion about this area really improving. So GSA is a professional membership society. We're the oldest and largest professional society dedicated to the aging across the lifespan. We have a really cool interdisciplinary membership, 26 different disciplines. We have docs, nurses, social workers. We have people who study human-animal interaction. We have biologists. We have the zoologists are the human-animal guys. We have dentists. So you name it. So we really get this 360-degree look at aging. And we're very different when you talk about the geriatric society. Those are people who take care of people 65 and older. We're looking at aging across the lifespan. So what are you doing when you're younger? What are you doing when you're older? What's the biology? What's the sociology? All of that stuff around it. It's really fun. And we really have 4 main our members. Many of them are researchers. So we have research around aging. We have people that are educating the next generation of experts in aging. We have people who are actually providing care, and we do have a lot of members who are involved in advocacy. A lot of our members, the cool thing about us when we go to advocate is we've got the science behind it, and it makes a pretty powerful message. And we certainly embrace diversity. Actually, the panel that Lisa was part of at our annual scientific meeting, which was in Tampa with 3,700 people this year, was all about
700 breakout rooms or something ridiculous like that.
It was a ridiculous amount of rooms. So they're like, will you do room checks? I'm like, sorry, I got a meeting. Because that's a lot of work. It's a big place. Anyway, Lisa was part of this panel that we had folks from the Alzheimer's Association, their chief diversity and equity inclusion officer. We had a gentleman who works with the Indian health system on the Native American and Native Alaskan population around dementia. We had Lisa, and we had somebody from the Human Rights Coalition Foundation to represent the LGBTQ+ community. So we really looked at diversity very broadly, and it was a great discussion. And we're actually going to be filming a webinar about that as well. And our vision is meaningful lives as we age. So why am I here now? And you're probably saying to yourself, why are you right here now? It is almost the end of the day, but thank you for sticking with me. So GSA was approached quite some time ago in around 2013 by the federal government saying, hey, guess what? They're not really using those Medicare annual wellness visits that should be part of, a big part of them is screening for cognition, screening for impaired cognition. So GSA is a great professional society and does what professional societies do. They pull together a work group, and that work group came together and put out this report. And this report is available on the website, again, freely accessible. But they both basically said this serious but frequent overlooked gap in healthcare. And it's all about inadequately or just not at all assessing people for cognitive impairment. So in this report, the CARE framework was first introduced, and it's KAER. I'm going to tell you about it. And 2 years later, in 2017, the first CARE Toolkit came out. So here's your opportunity to shine and tell me your first question, which is, what are some of the unmet needs for Ohioans? Am I saying that right?
Ohioans.
Yes.
Ohioans.
With ID or DD around brain health. What are some unmet needs? Let's shout out a couple.
Oh no, I have a microphone. I'm not going to shout it out. I'm going to say it gently into a microphone. Yeah,
access
I was going to say
special care.
I think a lot of times, just like anything else, we are dismissive of people with intellectual disabilities, so we don't bother to assess or get a baseline.
So potentially maybe the double whammy of this intellectual or developmental disability and now dementia that nobody wants to talk about either, right? Great. Education in general. So the stigma around dementia, right? We don't normalize brain health conversations. Great.
I guess we've had a lot of people in our county who've had dementia, and they tell us, the doctor's like, well, it seems like dementia, but they have a disability, so we'll never know.
And so diagnostic overshadowing. I learned that at the GSA conference. I said that like 10 times. And then she said to me, tell me what diagnostic overshadowing is. I go, I have no idea. And she said, it's what you've been saying all day long.
Finding doctors that know about your population. Hopefully the companion will help with that.
Medical professionals that feel competent to serve that community.
Those are a couple real good ones.
Yeah.
Can you save the chat log? Great, perfect.
Hold on, I'm going to get one more. Right. I think somebody's got, no, you didn't. You were just itching your head. Come on. No itching.
Okay, that's all right. We'll get you next time.
You'll have another chance soon. Don't worry.
Yeah, I hope. Why am I not looking ahead here?
Point to him. There you go.
Oh, but now I went too far. Okay, so I told you about our work group, told you about that report. 2017 GSA releases the first CARE Toolkit. In 2020, it was updated to the current version. And even though it says updated in 2020, know that it's like a living, breathing thing that we're constantly adding stuff to it. We publish what all of those additions are each month on a document on the website as well. I had the pleasure last August of launching this, the CARE Toolkit for Obesity. Is that something that your population could potentially use? It's around raising the awareness of obesity as a chronic disease and not a personality flaw or a character flaw or because you're too weak and all of these other things. You see some similarities with obesity and
and I want to bring up that what I've loved about working in this group about aging is that people that are county board staff, employees, whoever, we're interested for ourselves and our personal. It's also almost like a wellness thing, like the dementia friends at Summit. Everybody's like, I'm just going because my mom or my dad. But same thing, like this stuff, I never even knew that they were supposed to be asking me about brain health right now. And I'm,
Guess 50. They don't know either. Nobody knows. Nobody knows. It's a secret. So 2023 and beyond, we are continually working with amazing expert panels from around the country who help us refine this stuff and make it better and continually change it. 2024, we'll have a complete redo of this kit because there's so many things happening in brain health and dementia and Alzheimer's. And the green box, the new CARE IDDD. So you're probably like, Jen, you keep saying CARE. What the heck does it mean?
Oh, he's in front of it. There you go.
Oh, now I went too far. So here it is. The GSA CARE framework is kickstart a brain health conversation. So nobody can argue that having a conversation with you about your brain would be a good thing. Then assess for cognitive impairment using a brief screening tool. There's a couple of first opportunities there why we needed to do a companion. We needed to get some information about how can we communicate with this population that you guys serve, in addition to general positive communication. So I want you to understand that this companion is just that. It doesn't replace this. It goes along with it because it is all of the approaches that go in this main document apply plus, and the companion is the plus. Then so conduct this brief screening test. Well, guess what? All the screening tests that they might use for you or me don't work for somebody with IDDD, right? There's specialized tools The companion outlines them all in different tables, what their strengths and things are, and gives that for providers. If there is cognitive impairment, that's where the evaluation comes in. I believe firmly as a geriatric nurse or gerontologic nurse, that this sits in primary care. There are not enough neurologists to diagnose dementia. Most of them aren't specialists in dementia. They're specialists in something else. Everybody doesn't need to go to a neurologist. They can have dementia is often diagnosed because of ruling out every other thing, right? So how many times one of the things that like lit my fire to get this thing funded and get it developed was our colleague Kathy Service from NTG, who said to me that she has patients who have an intellectual disability. They call the provider and say they're more confused, and they diagnose them over the phone with dementia. So instead, take a look at, well, that person's now in a new, like one person moved from a very institutional setting to a group home setting, which we all think, wow, that's a really positive thing, except the person had lived in the institutional setting their entire life. And so when they moved, they left the people they knew, they left their friends. The person was profoundly depressed and was not at all experiencing dementia. They were experiencing some delirium related to this profound depression. So those kinds of stories really kind of were like, oh my gosh, are you kidding me? To me, that we've got to do better than that. And that was one thing that really excited me to get this companion going. And then the care toolkit, I mean, right now there's disease modifying treatments for dementia coming out, but what the care toolkit really highlighted is there is always something you can do. And that something might be wrapping that person in that unique bunch of supports and services in the community. And so you guys are doing that already, but certainly as maybe their caregiver is that older parent and this person's now experiencing some dementia. And so maybe that circle of support expands even larger, and there's even different possibilities of support that are out there. And so just a bit about the care toolkit is it is made to be used online. We print them out for things like this, but everything in it links to stuff that's outside of it. Each section has some key takeaways. I'm going to share those with you today. The idea is that, and I do want to mention that we do focus some on ways to get paid, because docs think overall you're not going to make any money. Dementia is not complex enough. There's actually great opportunities to get paid well for managing someone well. And there's even a new CMS payment model demonstration that's all about getting paid for chronic management of care with someone with dementia, which is really exciting. What we have in here is tables and exhibits, and throughout the text linking out to stuff that's the best of the best. Most of the stuff that's linked to this is not GSA stuff. It's evidence-based, research-based stuff that's out there. We talk about how to communicate effectively with older adults. When we talk about aging at GSA, we talk about we're all aging. It's not an us and them thing. We don't talk about silver tsunamis and doom and gloom of aging. It's, aging is a good thing, right? People who are aging often have different resources. They have different time. They have a lot of times a really, opportunity to contribute and things. So there's so much that we look at that I think, I always say ageism is in our country, to me, is one of the last okay-isms, right? It's okay to think differently about older adults. And then we do have additional resources. And new is, this is the name of our new toolkit, and that I'm going to tell you about today. And again, I want to acknowledge our collaborators, OACB, the National Task Group on Intellectual Disabilities and Dementia Practices, and the Ohio Council for Cognitive Health. And so what are our goals of the companion? We are really looking at raising awareness. So overall, it's looking at what are the unique needs of this population, and what are the key messages every primary care doc should know about that, or provider, I shouldn't just say doc. And then really equipping those providers, those healthcare teams, to engage in appropriate brain health conversations. So how do we get them engaged and get them understanding that this is important across the lifespan for everybody, but especially with folks who kind of have one stacked against them already with their brain, right? And promoting brain health conversations and early detection, and ultimately assist with finding those community supports that are appropriate. Believe it or not, sometimes even folks in our membership who are the experts on aging will say, why should I get an early diagnosis? There's nothing you can do anyway. We have a great podcast that stars Bonnie Berman from Ohio here that talks about why should you get that. There's so many reasons to get an early diagnosis, not the least of which is you may have opportunity to receive disease-altering medication, but there's also the opportunity to just engage in brain-healthy stuff that can help potentially reverse or slow that decline. So it's important. And so the first table that I want to point out, and again, these are all available to you, is just an introduction where we're really talking about, oh, I have these somewhere. Oh, there they are. We have these really looking at just a summary of dementia characteristics in individuals with ID, DD, or other neuroatypical conditions. So it really compares how do these things look when you're caring for someone with one of these conditions, and we break down all the conditions in this table, and how does that look different from the general population? So that's, oops. And so if we're looking at the general care framework, we're looking at starting with kickstarting that conversation. So we look at this as providers taking the opportunity to really raise the awareness of brain health overall, and that idea that there's so much research around prevention of dementia. Like if you get your flu shot, you're 40% less likely to get dementia, as when they studied a cohort. Is that because people who get their flu shots do what their doctor tells them? Maybe. I know if you, again, the hearing, if you're having hearing loss, and I have to tell you, my husband lately, I'm like, Dave, and he's like him and my dog have the same look now when I yell one of their names. They completely ignore me. I'm like, you need hearing aids. So hearing is a huge issue. Socioeconomic things, all of these things that impact dementia risk. And certainly people of color are way more elevated risk than people who are non-Hispanic whites. So we're looking at increasing brain health awareness, really working as a team. So I'm a nurse. If I'm working with a doc or a nurse practitioner in office, I need to be telling them what I'm seeing. The receptionist needs to know that if someone's missed 2 appointments and they never were doing that before, that's a change. Something's going on. So a whole team approach is not just nice, it's necessary when you're looking at this. And then actively listening for patient concerns and family concerns. Sally and I were talking a little bit ago, wouldn't it be great if we could just get every doctor to ask on their intake, have you noticed any changes in the way you think or remember since you were here last? Wow, what a victory that would be, right? To just answer that question. And so our approaches to implement for Kickstart are addressing sensory loss. Again, a story I heard this morning. Someone said, oh, your dad has some dementia? No, he can't hear worth a hoot. He doesn't have dementia. You're not talking loud enough, right? So we're taking care of those kinds of things. We're raising the topic of brain health and continuing the conversation, asking simple questions about memory and cognition, listening for concerns from people, observing for signs, and again, using things that are happening outside of just brain screening. So what is an EMR potentially? Maybe they have a new blood pressure medicine and there's been 3 blood pressure checks since and no change in their blood pressure. Is it perhaps because they never remembered to fill the script in the first place? So using these, maybe there's more falls, maybe there's other things going on, using those to really be triggers to see what's going on. Very quickly, I'm just going to tell you what is in this toolkit. And again, you can follow along and see this, look at it online. We have key messages about brain health. It's normal for older adults in particular to forget some things. I forget where I put my keys. I have the ability to track my steps back and figure out, or Bonnie and I were on a phone call the other day, Bonnie Berman here from Ohio, and she said, I know I can't find my keys right now, but I have the capacity to say, but I don't have to worry about that because I've got something more important to do and I don't need to find my keys right now, versus a person who loses their keys and says someone stole them, right? So there's a difference. There's some subtle differences, but some change with that cognition is normal. We do a whole momentum discussion podcast series. It's all free. All we want you to do is listen, but there's enhancing early detection. Why an early diagnosis matters is the one with Bonnie. It's out of sight good about why you should want a diagnosis earlier rather than later. So check those out. Resources for brain health for patients. We have lots of things, lots of handouts from Alzheimer's Association, from the Cleveland Clinic, McKnight Brain Foundation. They're just really good resources, kind of one-pagers about ways you can love your brain and things like that. So really nice, a lot of times colorful, a lot of times with pictures, resources to share with folks that how they can have a healthier brain. Again, this slide is just promoting brain health, and I think this comes from the Alzheimer's Association, the 10 ways to love your brain. And when you look at this, again, there are things that we've known a long time that are heart healthy habits in many cases. Cardiovascular exercise, so getting your heart pumping, hitting the books, participating in formal education. Your educational level is very closely correlated with, lower education, higher risk of dementia. But again, is that because those people with higher education maybe get better jobs and have more income and therefore have better food and better diets and safer housing? And maybe, but again, these are things that matter. But there's no question that challenging and activating your mind is important. Someone said to me yesterday, a couple of times a week, she brushes her teeth with her left hand, even though she's right-handed, and that she doodles with her left hand if she's in a meeting. And not that any of you would be doodling right now, I'm sure. But if you do, switch to your left hand because it'll be better for your brain. It just makes it hard and challenges your brain. I thought, I'm going to start brushing my teeth with my left hand a couple times a day. That's brilliant. Not smoking. If you have cardiac risk factors, taking care of those, addressing those. Wearing a helmet, not bumping your head, right? Bicycling, ice skateboarding, whatever. Sleeping, addressing mental health, and staying social. We know in the pandemic what a huge issue the social issues were for folks. So what does the new Kickstart Companion, what does it add to the CARE Toolkit? It talks about, again, engaging in those conversations over the life course and using strategies and language that are appropriate, and we include some examples of that. We look at incorporating caregivers in the conversations, both as informants and perhaps as interpreters as needed. And then establishing the cognitive and functional baseline. Perhaps we talk about video diaries and the value of having a video diary and looking at different ADLs or speech, the way the person might use fine or gross motor skills. Again, you guys know this stuff far better than I do. I'm sure you do this all the time. But it's really establishing that so that serial assessments over time. We stress that this is probably not a one and done with somebody, particularly in the IDDD community, that you've got to look over time and see what's really happening over time. And of course, we talk about disability inclusive language, person first language. I'm again, an old nurse. I used to teach nursing students, and if they called someone a diabetic, I almost went off the rocker. It's like, you're not a cancer-etic or a heart attack-etic. Why are you a diabetic? So it's a person with diabetes, a person with obesity, right? It's not an obese person. Their condition doesn't define them. And that's really important to me. It's like my crazy button, one of my crazy buttons. I'll be honest, I have a bunch. So I want to hear from you guys. Do you think about Kickstart resources? How could something like this be useful to you? How could it be useful to a primary care provider? Any thoughts?
It doesn't even matter because of what do you guys think? How could we use this as county board folks? I know. What do you think? Go ahead and say it. You can say anything. Say we can't.
Well, I mean, you can. I guess we do it. We're using it.
So can you get it out to people who don't do it?
What?
Can you guys be the vectors that goes to health systems or primary cares that serve your population, particularly those that don't know what they're doing perhaps so well serving your population?
Yes,
to get this out.
Yes, we are absolutely starting that process right now. And
wonderful.
It is. We're using the assessment, and it is really helping. It's helping the SSAs actually kind of figure out if there is more of a need, if it is out of medical stuff, or if it's just, it could be something else. So it's really helping them determine that, because it is very hard. So the SSAs are finding it actually very helpful as they're doing the assessment.
I think in Lucas, they're using the NTG early base, you know, that part. And I think that's a whole nother one. And I know Mahoney's doing some of that. And I think some other people are. That is something that certainly case managers can do. This will be very new. And this is almost, to me, more about sharing with families who would be taking their children to the doctors or going to the doctor themselves. Maybe you even are worried about the family member. How many of you guys have said that? I am so afraid that Joe's mom has, it's like, oh, well, maybe you should take this because we care for the family, right? But what we want to do is infiltrate the medical community, any nursing things we can do, the providers.
And wouldn't it be cool if we could train groups of physicians on, or providers, nurses, whoever, on the companion with you guys in the room where you're able to say, this is what this looks like in real life. To me, that would be a dream come true. Go ahead.
I think this is kind of out of the scope of my position, but I'm just thinking how amazing it would be if you had that expert in your county board, or depending on how big your county board is, many experts who can go get with the direct care staff and have these conversations. And the direct care staff even take it to the doctor. I think that would be more powerful than even an SSA.
Terrific.
Yeah. And I think direct care staff are vital. Oh, good.
And then we'll move on. Oh, yeah, we've got one online.
I was just thinking that, like, I have a case. I work in the behavior support department, and I have a person that was actually placed in the psych ward. And every time I spoke to someone, I was like, can we just, while she's there, based on her diagnosis, everything that we're seeing, can you guys assess her to see if she has any type of dementia? That was a big shutdown. Huge, huge. So I was working really hard and trying to see if I could speak to the social worker. Unfortunately, they discharged her without even doing those little assessments. And I'm thinking that maybe that should be some type of conversation that we should also be having when our individuals are committed, because of, it doesn't always have to be behavioral in that way. It could be something else.
Absolutely.
You know, we're ruling out medical. Let's rule out dementia at the same time.
Yep. Go ahead.
Sorry, I'm going on this. I can't hear online if we don't. Like.
So, I'm fortunate that I live in a community where we have a very large physician group that actually does a lot of these questions when you go to your annual check. Oh. But my concern is that they haven't adapted the questions for people that maybe have some. So I think if you have those adaptive questions, I think they'd be more than willing. But some of the folks that we support, because of their cognitive limitations, aren't going to be able to answer the questions that.
So we do have a whole table of the assessments that are appropriate and what works well with what. We have one comment online. This could assist dual providers of waiver with state plan services to be on the same page with the medical teams.
Yeah, that's nice. That's so we have state plan providers that are, you know, still funded by the same, but they also are DD providers, and they're in the homes helping take care of folks.
Oh, wow.
So that could be a really good group.
Great. So then we're on to the A of care. So KAER, assess for cognitive impairment using a validated brief tool. Now, some of the tools for the IDDD population aren't so brief, but I think that there's reason for that, right? Because they're going to be informant-based in many cases. And again, hopefully we can get providers on board of just, again, asking some simple questions. And the idea here is to determine if further evaluation is needed. So remember that even in us, in the general population, if you do a mini cog or one of these other screeners, it is not diagnostic of dementia. It will give you a clue if there's something going on with cognitive impairment, but there's a whole nother diagnosis process to go through. And again, we emphasize whole team here. So a couple quick what we're doing here. It is all about using validated brief tools for families, for individuals, and actually even so a test on someone, a screening tool, then also gathering their feedback about what they think is going on with their cognition and the informant based. And then having office staff participate. So in our care toolkit, we actually have some exemplars of how medical assistants were trained very successfully to do the screening. So when docs, it's always, we don't have enough time, but it's using that time wisely, right? How could the medical assistant spend 3, 4, 5 minutes with somebody to get this?
Yeah. And I do think that some of the counties are starting to train some of their SSAs to do this. And and so that, you know, certainly within the Down syndrome world, but also just in general, I mean, we have people living, we're going to be celebrating. There's going to be a big old 99, 98-year-olds in various parts of I mean, we have a lot of aging people in our system. And I love that this isn't just wait until they're 65, right? It's super important to think about it early.
Yep. And so here, just some examples of things in the regular toolkit. Brief screening tests, we have them available in a multitude of languages. I think it's really important to mention, though, that any of these brief...
It's being blocked again. It's the Q&A block.
Yeah, really. When I'm like doing that over and over, it means you might have to hit that button. We're looking that things that have been translated in other languages are just that, translated. They're not adapted. So in some cultures, there's not even a word for dementia. It literally means crazy in some languages and things like that. So it's really important to understand that conversation. And so you guys have another layer on top of that, right, of different cultures and backgrounds, plus there are other diagnoses. And then there are family questionnaires and self-reporting decline as well. And so what do we do in this new toolkit? This, I would say, is probably one of the biggest sections, actually this one and the next. We're taking a look at stressing that issue of that diagnostic overshadowing. Don't just automatically attribute this to their condition. Do some additional looking and saying that, are we able to document, again, that serial, serial assessments, that we're taking a look at how do we have to adapt different tools to different sensory needs, maybe listening devices, large prints, things like that, looking at those longitudinal assessments, using cognitive screen assessment tools that are specifically appropriate for the different population that is of that person that you're caring for. And we've got a great table that lists all of these, a couple of tables. And then capturing information about that history, really looking at that from the informants. And again, these are things that you guys already know and that you're experts in. And to me, this is where you can be really valuable in educating providers in this community, in your larger communities. And so here is the recommended assessment. We actually say what condition is here, what's the frequency, what measures should be used, what are some adaptations you need, what are some barriers, and is an informant useful or absolutely critical to have as part of the assessment? So
it says useful, always have an informant.
And then it's like vital or critical or something like that. So what do you think here as far as how could you use this info? What do you think about resources that might be available here? Any thoughts about the screening tools? Any thoughts about the idea of serial assessments? Any thoughts about video assessments, capturing that person's baseline and how you can help drive that? Go ahead, Lisa.
We gotta run. See, Kristen already answered this part because she brought up the NTG assessment right off the bat. So she was right on target. You're an overachiever, Kristen.
I did appreciate the emphasis on having a multidisciplinary team. I'm also a nurse, but I'm married to a pharmacist who specializes actually in geriatric neuropsych. So this is his whole wheelhouse. And the number of times where people have come to him thinking that they had a memory disorder, and it was actually because they were taking Benadryl. And Benadryl is not a safe medication in older adults. Throw away your Tylenol PM. And so that is something that other professions might not consider. So having multiple people weighing in, you're going to get a more complete picture.
Excellent.
Thank you.
That sounds like that might be a quote. We're going to need to write your name down.
Maybe. Yeah, I was going to say, I think we need to talk to her pharmacist. I love that. That's a whole nother area that we have some great pharmacists. Anybody else with ideas about?
Oh, we got a chat online.
All right.
Capturing a baseline is huge. Sometimes people who are closest do not see the changes happening or recognize that changes that are occurring are implications of something more to explore. Thank you, Anne. We might be using that as quote too.
Ann Tapia from the ODD. She's really integral in this group also. So,
I just wanted to, I guess, mention also a couple things that have developed during the pandemic, quite frankly, are some of the more virtual modalities. And so Station MD has been a big success, our health services coordination with nursing. And so having some of these pre-screen diagnostic tools in place to kind of set the stage for a different type of conversation, virtual or otherwise.
Great.
That's awesome. Yeah,
Awesome.
I connected Jen with Station MD yesterday to kind of say, let's make sure they have this information since they know. And I love Franklin County is one of the counties that originally reached out and said, hey, what are people doing? So thanks, Jeff.
Thank you. Right. And then we go to evaluate for dementia. So here really is the part that we're looking at a diagnostic evaluation. One of my favorite tables is actually in this section of the toolkit. It's all about dementia diagnosis is often we're ruling out everything else, right? We're ruling out meds, we're ruling out infection, we're ruling out delirium, we're ruling out all of these things, checking that person through this robust assessment process. Then if we say, yes, we believe they have dementia, then we're figuring out the differential diagnosis. Is it Alzheimer's? Is it Lewy body dementia? Is it a vascular dementia? And so we provide in this a whole bunch of resources to help providers, one, do that thorough workup. Even if they feel the need to refer someone to a neurologist, we want them to do the things that squarely sit with a primary care provider, like ruling out the reversible causes, doing the med review, doing these other things that can really help to drive the appropriate diagnosis. The worst thing is that they get to the neurologist 6 months later and all those things that could have been done at primary care haven't been done. So what do we do with our approaches to implement in this? Oh, I'm going the wrong way. 2 forward, please. Thanks. We are supporting individuals and their families in understanding why it's important to get a diagnosis. And again, that issue of what are we going to do anyway? We know that that's not true. Even different supports and services, education, planning, things around that line are really important with early diagnosis. Conducting that diagnosis, and then again, the differential diagnosis, what is causing that dementia or potential multiple causes, documenting that, disclosing it. And there are some great videos that are embedded in the toolkit about that disclosure. And then when indicated, also involving the family. With the evaluate tools and resources, this is my favorite table. Go ahead, please. Figure E1 is my absolute favorite thing in this toolkit. It's 8 parts of a comprehensive diagnostic evaluation. And you'll see down on the very bottom that specialist referral is suggested in certain cases, not across the board. But this talks about what is the physical assessment, what is the cognitive assessment, what's the lab work and things, what other types of diagnostics are needed. So it really is a framework that the providers can use because of the emergence of blood-based and other fluid biomarkers and things, and just the science moving so quick. This will be something that we're really keen on updating pretty significantly this year. But this basic stuff doesn't go away. We're just having additional things on. But the primary cares are the people who are getting the question of, hey, I hear there's this new blood test about Alzheimer's. Should I be having that? And so they need to at least, they may not be the person that orders those initially, but it's probably going to sit in their wheelhouse at some time. And they at least need to know how to have a conversation around that with an individual. We do have a lot of other additional GSA resources. We just published this agitation and Alzheimer's disease. And actually at our conference, they released a new screening tool. It's 1 minute to detect agitation. It's a terrific tool that's based on the International Psychogeriatric Association's criteria for agitation in dementia. It's terrific, freely available as well. Go ahead. Oh, wow, now I'm going too fast. There we go. And then we do have all of these tools and resources that help to sort out the various causes of dementia. And again, they're all different associations and things. And then several resources about that disclosure. And those are there. And then, so what is our new care kit? Look at, again, detecting that thorough diagnosis. And we stress, we actually have it written here. Dementia is often a diagnosis of exclusion. So you're basically saying it can't be anything else. They must have some kind of dementia because we've checked it all. And so we talk about the need to look at, again, is the functional decline or clinical cognitive decline because of meds? Is it due to, thyroid, nutritional changes, all of these simple things that can, or potentially not so simple things, but that can be treated. So we want to make sure that the exclusion is done with this population, just as it is done with the general population. It should not just be checked they've got something that really makes them at high risk for this condition. And then again, this is where we really discuss diagnostic overshadowing and what an important condition or what an important concept that is. And just kind of saying, oh yeah, that's going to, bound to happen. My background is a lot of it in nursing home nurse. If I had a buck for every time somebody said to me, they're just like that. They have that. They're always like that. I would probably be on a beach and not here in Ohio in the middle of winter. I'm from New York. Please don't think I'm bashing your winter. Whatever you guys get comes to me. So, but anyway, it is that normalizing decline, right? And that's what we're trying to get ahead of here. And that's how I battle that in the nursing home. It's not how they usually are. Let's talk about what's different today. And then you guys doing that, again, the advocating for it's not just a progression potentially, we need to check. And then identifying the conditions that we can treat. And then, again, looking at the thorough evaluation for those symptoms in addition to physical exam and cognitive evaluation. So how do we do that? And again, interdisciplinary. I love the talk of interdisciplinary, and that's, to me, that's the secret sauce of where I work. GSA is that we're all interdisciplinary all the time. We never work alone, which makes it fun. There are 3 tables associated with this. And again, these are in your handouts, but the 3 tables are conditions that may cause memory changes. So we actually give them sensory, metabolic, coexisting mood, farm, sleep problems, seizures, all of these things. So we give presentation of these symptoms and what they may be. We talk about the components of the evaluation. So layering on what we already have in the care toolkit, what are some specific components that are most important for this population? Looking at that. And then examples, again, of the screening tools and the assessment tools. And that table is a page and a half. And I had to shrink down the font to get it on a page and a half. So it's very, very comprehensive, where it talks about the strengths and weaknesses of those different tools, so that the providers can make, hopefully, an educated decision about what might work best. And so what do you think about evaluate? Could any of that stuff be useful? When I mentioned the different tables, when we talk about the concepts, any thoughts you want to share? And our chatters online, thanks for participating. We welcome your feedback still. You guys losing steam on me?
I know. We're like, oh, we can make it. We've got it. I think it's overwhelming because it's like, it feels very medically based, and it's, it's like, how much what can we do?
So I think about the tables that I just mentioned. It is medically based, but I also think you guys are the advocates, right? Mm-hmm. And the people who are the direct service providers who are going on appointments. I mean, I think about when they say, that's probably just dementia because it's so common with people with this condition. They can say, but have we checked things like their electrolytes? And have you looked at their med list? Is there anything there that might be going on? I think of this conditions that may cause memory changes as a golden nugget for you guys who are able to go out and use this to question the provider, right? They should be, hey doc, have you seen this list before? Yeah. Let me share it with you. Wouldn't they love it? When I first, I was at Benjamin Rose Institute talking about this care kit, somebody went to her doctor the next day and said, all my mother and my aunts all have Alzheimer's. Why aren't you talking to me about this stuff? Mm-hmm. And I'm like, you go, girl.
Yeah.
That was
I think that's the key, is that it's not just about the people that we serve. This is more having the discussion about your family members you're worried about, you, whatever, because the more you use it for that, you're going to be okay talking to people about somebody with IDD. We're good at advocating once we know. It's just that we don't feel like we even know.
Lisa, and you also have the lady right behind the lady in the green jacket.
I was going to say, I was just thinking, so I was listening to something recently. Sorry, this is a larger thought, but they were talking about how culturally speaking, we haven't made a lot of strides toward addressing kind of our own stereotypes or our own dismissiveness toward three populations. And of course, it was people with disabilities, and then it was people who are obese, and then it was our aging community, right, or our seniors. And so I think like such a big part of this really is just continuing this conversation. This is an easy thing for us to take back to our folks and say like, hey, SSAs, don't forget this. But then it has to be part of an ongoing conversation so we don't forget. That's exactly what you're saying, right? Like, keep talking about this so that we're mindful, and we can take these resources, which do feel overwhelming, and say, here, medical professionals, don't forget this piece. So that's my big takeaway.
All right, and we're going to take one more comment here, and then we'll get to after, because we are running out of time.
Yeah, who was the other one?
Right
there we go.
Oh, and we have a comment online too. Okay. Go ahead.
I just think taking some of the stuff to meetings and saying it doesn't necessarily is this, and giving them other ideas that it could be, is going to ease a lot of that stress.
Great. Wonderful. That just knowing that there's something, I mean, it's, oh, providers don't learn about this. They don't learn about old people in school either, just so you know.
Yeah.
Or obesity. And so we had a comment here. These tools offer the team and family language that will help medical professionals to take it more seriously and more quickly. I love it. All right, we are going to take one more.
There's one more, right?
You guys aren't going to give me the hook right at 4:30, are you?
You can do something. Anna does all kinds of cool things.
This is more of a comment, I guess, but I thought it was very valuable that you talked a lot about that there's options if it's detected early, because I think culturally we're given the messaging that you should be afraid of this, but if you get it, you're screwed, right? Yep. Like there's nothing you can do. It's just going to happen to you if it's going to happen to you. So I feel like knowing that, knowing a lot of the things you can do early to be proactive is helpful, because I don't think we hear that as.
Absolutely. Well, it's a diagnosis of tragedy, right? When somebody says dementia or Alzheimer's, life is over, right? But in fact, you can live really well with these conditions for a long time. And one of the things Bonnie says to us is that the people who are diagnosed early are like the soldiers in the field to advocate for Alzheimer's care. They're amazing. They're the greatest advocates. They're fellow board members with me in the Alzheimer's Association. It's really cool. They're amazing advocates.
Yeah, they help strive. And I would invite you to get involved in a Dementia Friends training or something. That's probably, that's what got me excited about this stuff. And we have a lot in Ohio. We've done really well. There's multiple counties. So if you need information about Dementia Friends for your staff, that's a great activity to just start talking about it, and that it's not the end of the world. It's not a death sentence. And then you can get into some of this other stuff.
All right, I've got 2 minutes, and then I know you're going to give me the hook. So refer for community services is the last, and this is all about getting the person with dementia and their care partners connected with community services, and understanding that receptivity to those services and to education changes and evolves over time. It is all about this ongoing need to provide that, and to encourage folks to be engaged in clinical trials if appropriate. And so again, it's all about referring them to people on the team or people outside of the direct care team, conducting the regular follow-up and providing information. And we do have a really nice referral tool that is downloadable. Anybody is welcome to use it, but it just really says, here's the referrals that this person could use. And we have an awesome interdisciplinary approach to community referrals. This is my colleagues down at Emory University. It's terrific. Podcast. And then, so what do we have in the new refer section? Again, referring to community supports, sharing the diagnosis, adapting approaches used for the general population. We know that research around pharmacological and non-pharmacological, my watch just recorded everything I said, by the way, from the time it said I have 2 minutes. We know that folks from the IDDD community are underrepresented in research, as every minority group is, right? But we also know that there's general consensus that the approaches, whether they're pharmacological or non-pharmacological, that apply to the general population should be adapted for the individual from that community. So we talk about that. And again, individualized care planning. There are some neat tools and resources here. Post-diagnostic support. So there's a whole table about post-diagnostic support. To me, that could be very useful for community health employees, support people. And then we also have strategies for managing dementia. Again, super valuable for anybody who's in the life of a person with dementia, with ID or DD that has dementia, or any neuroatypical condition that has dementia. And so this is my final chat. Do you think that those tables and resources might be useful in the community? Any thoughts? Anybody want to have the last word?
Come on, you guys got it. Yeah.
Just yes, they'll be useful.
Come on, Jeff, put more to it. We got to get this in the, Jeff said yes.
Yeah.
Just a takeaway I have is that it's rare to work in a field where you carry people across lifespan. You guys are doing that as a disciplinary. And so I just think having these touch points as benchmarks and then empowering our staff to have these conversations is really important and powerful.
Great. Thank you. Wonderful. And with that, that's my email. I'd love to hear from you. We are really fortunate that we have support to do things like I'm doing today, to come out and train groups on this resource. We want to come and tell, if you guys say, I want to organize a training in my county and we're going to invite the neighboring counties or whatever, and we want to learn about these resources, get in touch. If you want a webinar, right? We can do a webinar like that. So think about that. We know there's some really cool grants that are happening in Ohio, and these resources are probably going to be folded into those grants. So they are going to get some more traction. We love Ohio. GSA is like, yay, Ohio. Bonnie Berman is on our Care Toolkit advisory panel. Lisa's on our Care Toolkit companion advisory panel. So we know Ohio gets stuff done. And so we want to be part of that wagon as well. So I thank you guys for sticking with me. I'll see you later this evening. Thanks for the pleasure of your company here today and for your interest in this.